All right, well, we've got some folks still joining. I'm going to go ahead and get started here. Welcome, everyone. Good afternoon. Welcome to the Oregon Bioethics and Humanities Colloquium. Our presentation today, Transparency, Mandates, and Ethical Obligations, Biopsy Result Disclosure in the Era of the Cures Act by Dr. Clara Bosco. My name is Cliff Coleman. I'm here with the OHSU Center for Ethics in Healthcare, and I co-chair this series along with Dave Hoyt, who's with us as well. Today's talk continues our 2025-2026 Oregon Bioethics and Humanities Colloquium, or OBHC as we call it. And today's our fifth out of seven talks this year. Our speaker series tackles complex issues and critical questions in bioethics and the medical humanities. I'm really delighted to introduce our presenter today, Clara Bosco, MD. Is a third-year general surgery resident at Northwestern University Feinberg School of Medicine in Chicago, and a recent graduate of the McLean Center for Clinical Medical Ethics Fellowship at the University of Chicago. She earned her bachelor's degree in philosophy from Creighton University and her MD from the University of Wisconsin. Since beginning her medical training, Dr. Bosco has continued her philosophical scholarship, conducting research in bioethics and the philosophy of medicine under the mentorship of our own Dr. Fabrice Jutterend. And their collaborative work has explored the impact of artificial intelligence on the doctor-patient relationship and the role of practical wisdom in clinical medicine. Dr. Bosco's current research focuses on surgical ethics and the ethical complexities of patient communication through digital platforms such as patient portals. Please join me in a warm OHSU, Portland, and OBHC welcome to Dr. Clara Bosco. Clara, take us away.
Awesome. Thank you for that really kind introduction, Cliff. I'm very excited to talk about this topic. As a resident kind of in the depth of the clinical world, this is something that I see kind of daily issues with, and it's cool to kind of apply some of the things I learned at the McLean Center in thinking about how to make this a little bit better. Just before I get started, I do want to give a shout out to my mentors, Dr. Peter Angelos and Dr. Battershakshire, as well as Dr. Fabrice Jutterend, who is kind of the reason I'm here talking about this today. So over the past few years, we've seen a major shift in medical practice in the US with the final rule of the 21st Century Cures Act, which was enacted in 2021. And as many of us know, especially those of us in clinical practice, patients now receive immediate digital access to all of their health information, including tests that can be highly distressing or life-altering, like cancer diagnoses. This push towards transparency is often framed as empowering, and in many ways, it totally is. But it also raises serious ethical concerns about what it means for patients to receive sensitive or life-altering information without physician context, guidance, or interpretation. So we designed a study at the University of Chicago that focuses on this exact ethical tension. We wanted to better understand how patients themselves think about trade-offs between getting their results quickly, but also having physicians involved in this process. Using online surveys, we're asking patients to make forced choices between immediate biopsy release and delayed physician-facilitated disclosure, allowing us to examine how patients navigate this balance between timeliness and clinician support. So kind of breaking up how we'll tackle this large topic, I think starting with the legal background and what the Cures Act is meant to kind of accomplish is important. And as we as ethicists know, the legal and the ethical are always intertwined. And then we can move on to talk about specific challenges that physicians and patients have kind of published in the literature or even online about issues with this. Beyond the challenges, we can then dive really into the ethics of this and really the tensions that are at play. And then I'll briefly go over our study kind of design, how we got it up and running at U Chicago. And just as a disclosure, we only have preliminary data. So this isn't, it's still a work in progress, but I'm excited to kind of show you how far we've come with it and some of our preliminary results. So So getting into the fun legal background, this 21st Century Cures Act was passed in 2016 under President Obama, and it was with an overwhelming majority. This bipartisan law describes the tripartite mission of discovery, development, and the delivery of 21st century cures. So to this, Congress committed over $6 billion in funding across several domains, which include speeding biomedical research, accelerating drug and device development, addressing the opioid crisis, and improving mental health. And there's a ton of things beyond this, but one part of it I want to focus on is the All of Us research program. This is a major pillar that sits within the NIH. It's a national precision medicine effort designed to collect large-scale health data from diverse populations in order to improve individualized care. I mean, it's been massively successful. More than 800,000 people across the US have enrolled. And importantly, a vast majority of these people come from historically underrepresented groups in medical research, which is great. Participants are able to contribute electronic health data, biospecimens like urine and blood, survey responses, wearable data from smartwatches and things like that, as well as genomic data. Seen in this light, I think it kind of makes sense and shows why that there's a push for immediate patient access to health data from the government. So this transparency isn't only about kind of empowering patients and promoting autonomy, but if patients have immediate access to all their data, then they're then able to share and upload that data to these large-scale data sharing initiatives like the All of Us campaign. And this is ultimately to develop cures and better treatments. Another focus of the Cures Act, which I think is cool to mention, is something really good about it, is focusing on improving the FDA approval process. So $500 million went over the next 10 years went towards implementing changes in this area in order to speed up the approval of pharmaceuticals and devices without compromising safety or effectiveness. And I include a crazy picture at the bottom here. And this is the process that a drug or device has to go through in order to actually reach and help patients. And this process right now can take between 12 and 15 years, so super long before it's actually being used. So while most of the Cures Act that I've talked about so far is oriented towards research, the final rule is kind of where I want to dig in now. And this is where it really kind of reshapes and directly impacts clinical practice every day. And this is where the interesting ethics kind of comes in. So the final rule was implemented in March of 2020, and with the compliance requirement of 2021 of April. And its stated goal is to ensure what the law calls seamless and secure access, exchange, and the use of electronic health information. A key mechanism for achieving that goal is prohibiting what's known as information blocking. The definition here is intentionally broad. So they say any practice that interferes with, prevents, or even materially discourages access to electronic health information when the entity knows it is likely to do so. So any of that can qualify as a violation and as information blocking. And what's interesting is this rule applies widely. It covers not just health IT vendors like Epic or data exchange vendors, but also healthcare providers themselves. So in other words, clinicians and healthcare systems, healthcare vendors are all within the scope of this, this regulatory law. Importantly, the penalties are not trivial at all. They talk about up to $1 million per incident if found kind of, if you have promoted information blocking or not kind of released data directly to patients. And something I want to get into next is this quote, and I actually found this directly on the website of the Office of National Coordinators for Health Information and the ONC, or the ONC. The ONC is a federal agency within the HSS, and they're responsible for interpreting and enforcing health IT provisions of the Cures Act. So in practice, this is the body that tells healthcare systems and doctors what does and what does not count as information blocking. And I think what is striking about this passage is how explicitly it addresses routine clinical behavior. The guidance states that an organizational policy that delays the release of a lab result, even briefly, in order to allow for clinician review, this would be probably or most likely considered an unlawful interference. So this is not hypothetical, and this is exactly what I think a lot of clinicians would want to do, specifically when it's a life-altering diagnosis like a cancer biopsy result. So I think that this quote directly from their website kind of does a good job of painting the tension. So now turning more to the medical and ethical literature, the immediate release of sensitive results has created real-time challenges for both patients, physicians, and ethicists. And I want to highlight some examples. The first paper has a really jarring title. It's a 2023 case report that was written by obstetricians in Colorado, and it's titled, "I don't think it should take you 3 days to tell me my baby is dead." This case involves a young woman who presented for a routine second trimester ultrasound, and during the scan, the sonographer detected absent fetal heart tones. And as kind of for the workflow, sonographers, they might know this, but they're not physicians, so they're not the ones that can, diagnose this condition. So the patient was told that her physician would contact her with the results as soon as possible. However, once the radiologist had finalized the report confirming fetal demise, it was automatically released to the patient's portal. And she actually learned of the loss through her chart. And I think she was actually driving home or something kind of crazy. So in this case, the patient luckily was able to reach her physician, who was deeply distressed by how kind of this occurred after the Cures Act was enacted, and the physicians and their colleagues were able to escalate this incident within their healthcare system. And they actually were able to request a 72-hour delay. The next paper is a paper by an oncologist, and the oncology community, as you can imagine, has really been kind of hit by this hardest. But this was just months after the final rule went into effect. He describes how in the first month alone, 2 different families spent hours researching the phrase, quote, "white matter changes" on a brain MRI for elderly relatives. In both of these cases, this is a relatively common finding and clinically insignificant, but it obscured the good news of those MRIs, which was that there were no brain metastasis. And so I think something for me too, these instances raise an important kind of practical concern for us physicians. Entirely normal results in clinical medicine are super rare. It is like very rare that I'll look at a CBC or a BMP of one of my patients and nothing is red. So but just because it's, not entirely normal doesn't mean it's clinically significant. And that's where physicians, we need to come in and kind of explain that to our patients. Okay. Now that we've kind of highlighted some of the ethical concerns, let's focus in on what physicians specifically feel about this and kind of what we see in the medical literature. This is a really good 2016 paper that surveyed oncologists, and they found that 87% thought that there was a harmful effect when patients received abnormal or confusing pathology or radiology results before talking about them with their physicians. So a little bit of concern there. But it's important to note that though the oncology community has definitely been hit by this, debatably the hardest, it's not just oncologists that are worried about this. Here's another paper. This is a study that surveyed over 300 physicians in both the US and Australia. They found that 45% of those physicians were primary care doctors, and then almost 50% were non-oncology subspecialty physicians, so surgeons, all sorts of different types of doctors. And they found that only 21.3% were comfortable with directly releasing clinically significant abnormal results directly to patients. Interestingly, they also investigated if physicians were comfortable with the direct notification based on the type of test. So is it just any test being released, or does the type of test and how sensitive it might be matter? And they found that over 3/4 of these doctors were uncomfortable with the direct release of HIV results, cancer screening, and chest x-ray. And kind of unsurprisingly, HIV results were the highest at 85.9% of physicians being uncomfortable with direct release of this. So that's doctors, but what do the most important stakeholders in all of this, patients, think about this new paradigm? So overall, reading through the literature and kind of designing our study, they tend to be more supportive of immediate release since they want their results understandably as quickly as possible. So in this 2022 study published in the American Journal of Surgery, they surveyed both physicians and patients, and it's cool. I'll show you some of the graphs, but it kind of directly compares what physicians versus patients think about some of these things. So out of 69 physicians and 57 patients that responded, they found significant discrepancy between the two groups regarding the immediate release. So some specific examples include when asked if making all results immediately available to to patients is a good idea, there is significant discrepancy between patients and clinicians' responses. 77.2% of patients agreed with this statement, whereas only 16.4% of clinicians agreed. So that's a huge difference, obviously. Another example is patients and clinicians also disagreed about whether making results immediately available would improve patient understanding of their health and medical conditions. For this, 73.7% of patients agreed with the statement compared to 16.4% of clinicians. While patients are generally more supportive, as we just saw, they also might agree that not all information, not all healthcare data should be treated equally. So this study by Bruno and colleagues in 2022 was done out of the Cleveland Clinic, and they had over 8,000 respondents. Their goal for this project was to better understand how patients view emotionally sensitive information and should it be treated differently, kind of going back to the common theme of is all information treated, should it be treated the same? Here, majority of respondents were accepting of first learning their test results from the electronic patient portal for cholesterol tests and strep throat tests. However, most respondents would prefer an inpatient appointment for serious tests such as cancer and fetal miscarriage. And this is a beautiful graph that they have that kind of shows that decreasing comfortability as the tests get more and more serious. And that's in this column. So now for the things that we're interested in and the fun part of all of this, and using a principlism frame, most of the justification for immediate data release rests on the respect for patient autonomy pillar. The idea that patients own their own health data and they have the right to access it without interference or delay. So the ethical question becomes, should respect for autonomy always supersede the other pillars? So should it supersede non-maleficence, which is the obligation to avoid causing harm? Or put differently, are there certain categories of health information like pathology results, genetic findings, or prognostic results that are ethically distinct from due to their potential to cause significant harm when delivered without physician support? So we argue that the current regulatory approach largely treats all health data as the same, and it assumes that this one-size-fits-all model of disclosure regardless of the content, clinical significance, or emotional weight of the information being released. And we think that this assumption could be harmful and is, something to be evaluated. It also, beyond non-maleficence, raises questions about beneficence. So whether or not we are actually promoting patient well-being, and also questions about justice, particularly for patients who have less health literacy, fewer supports, or limited access to clinicians who can help interpret their results. So as a first step in answering all these big philosophical questions, we wanted to better understand the patient perspective, as they're arguably, like I said earlier, the most important stakeholder in this discussion. So this slide kind of outlines our study design. And one of our central goals was to kind of access a population that's most directly affected by this. Some critiques we had of the literature that I talked about previously is a lot of those studies were asking patients in general, like they would have it on an intake, like a survey for intake, or just anyone who's getting a chest x-ray or something. But we didn't want to focus on patients in general, but on patients who are actually at risk of receiving potentially life-altering results to their phones. So to address this gap, we focused specifically on patients who were scheduled for image-guided biopsies, individuals who know that the results they are waiting for could be potentially emotionally distressing or life-altering. From a practical standpoint, the radiology team first generated the list of MRNs for patients who were scheduled for biopsy. Those MRNs were then sent to the study team, who were added to the study. And once identified in kind of that pre-biopsy phase, they were then sent a survey to their MyChart directly. So just go directly into their inbox. And so by studying patients in this moment, when the stakes are real and not just a hypothetical concern, we aim to capture preferences that are more ethically and clinically meaningful. So getting into a little bit of the specifics of the survey, we wanted it to be really short, so between 5 to 7 minutes, and we have it broken up into 4 main sections. We have components that are more traditional survey questions, where we ask about demographics, thoughts about upcoming biopsies and their health information. And then what was a little bit unique about our study is we use discrete choice analysis, which I'll explain in the next slide. But this is a way in which we're actually forcing patients to make trade-offs between timeliness and physician involvement. So the first kind of aspect of the survey is they'll get those traditional aspects, which we'll actually review kind of more in detail later. But going through the discrete choice, which is sometimes called a conjoint survey, to study the trade-offs. This method is commonly used in economics and health services research to understand how people weigh competing features when they have to make real choices. So rather than asking patients directly, do you want immediate access or do you want physician involvement, we presented them with a series of paired scenarios, like I've shown kind of here on the screen. With each choice set, patients were able to pick which option they preferred. For example, immediate online access versus a short delay with physician involvement. They repeated this process across multiple combinations of timing, method of disclosure, and clinician involvement. By looking at the patterns across these choices, this method allows us to mathematically infer what patients value most. These inferred values are called part worth utilities in fancy statistics terms, but basically, you don't, and this is kind of a picture or graph of how it will look, and you don't need to focus on the numbers, but the more positive the value is, reflects a stronger preference. 0 is indifferent, and then negative is a lower preference. So one advantage of this approach and why we adopted it is it mirrors real world decision making. Patients aren't just evaluating one feature at a time, they're having to weigh trade-offs. And then the other great part about this method is you don't have to ask every single combination. You're able to derive preferences. After spending all that time talking about discrete choice, though, unfortunately, we're still in data analysis for that part, but I'm able to share kind of the traditional survey results that we've obtained, and then we can kind of reflect it back on the ethics here. And then I just have kind of a disclaimer that these results are, in progress, they're unpublished, so just not to kind of share them. Okay, so first we can kind of go through some of the demographics and responses. So currently 87 responses with a 10.2% completion rate. Interestingly, the age is above 60 and ranging between 30 and 87. And this part I do want to get into when you look at how our education levels are kind of broken up, you can really see a skew here. So our sample skews older, predominantly white as well, and highly educated. Kind of thinking more about this likely reflects those who are most engaged with my chart in general, and I've included a citation here rather than a really general population. Portal use is strongly associated with access, health literacy, time, and then comfort. So people who are highly engaged and feel comfortable using technology and have the ability to, I think is kind of reflected in the demographics on this slide. But as we'll see later, even in this highly engaged group that has access, they still were much more uncomfortable with receiving abnormal results without physician involvement as compared to normal results. And we'll kind of talk more about that. Okay, so this slide goes into some of our data, getting into how patients approach biopsy results. So first, most of the respondents are not biopsy naive. Over 80% of our participants had had a prior biopsy before. So these patients have lived experience of diagnostic uncertainty and are definitely not first-time comers to encounters like this. Second, patients reported a high level of understanding of why the biopsy is being done. So nearly 90% say that they understand the purpose very well or extremely well. So lack of information or confusion about the procedure itself is not a primary issue per patient report. What's striking is why the biopsy is being performed within this population. So the vast majority of these participants, over 85%, the primary reason was to determine whether a lesion is cancerous or not. So this is very critical in interpreting our findings. These are not low stakes incidental tests, kind of like reflected in the other papers I had talked about, someone just coming in for routine labs or just getting a chest x-ray for screening if they're a smoker or something. These people are facing real possibilities of cancer being in their future. And this carries obviously a significant emotional and existential weight. In this sample, just over half of respondents reported having been diagnosed with cancer at some point previously, and more than 1/4 report an active cancer diagnosis at the time of the survey, which is also interesting. This indicates a substantial proportion of participants who are engaged in the biopsy-related decision-making process in the context of either current or prior cancer, kind of like we were talking about before. In addition, nearly 40% of respondents report a history of anxiety or depression, and this suggests an important psychological comorbidity in patients who are on this cancer diagnosis kind of pathway. And we thought that this is certainly relevant to whether or not you would want things sent immediately to your phone or would want to travel and see a doctor to talk about it or talk more with other people. So definitely an important comorbidity to kind of assess in this population. Okay, so these next two slides are kind of the meat. They're very critical for the ethical tension at the heart of this work. So first, looking at how long patients feel it is acceptable to wait for results, we see a clear distinction between normal and abnormal findings. So for normal results, most respondents are comfortable waiting 24 hours to several days, with relatively few expecting immediate notification. In contrast, when the results are abnormal, expectations shift towards more rapid disclosure, with a greater proportion indicating that waiting longer than a day is not acceptable. So this suggests that patients value timeliness for serious information, but that doesn't necessarily mean that they want immediacy without context, as we'll see next. So the second slide kind of helps clarify that distinction. So when results are normal, most patients report being very to extremely comfortable with receiving information without clinician guidance, while only a small minority report discomfort. However, for abnormal results, the pattern reverses. Nearly 40% report not being comfortable at all with receiving abnormal results without the guidance of a healthcare provider. So that's not comfortable at all. And only a fraction report high comfort. And what I'm excited about, specifically kind of with the discrete choice and then getting into a regression kind of analysis of this data, is who are those people that are actually extremely comfortable with that? Do they, what kind of demographics do they come from? And then kind of parsing out those trade-offs as well with the discrete choice. So taken together, these findings highlight a central ethical point. Patients do not view all healthcare information as ethically equivalent. They distinguish between normal and abnormal results, valuing speed for serious findings, but also placing significant importance on clinician involvement when stakes are high. The data challenged the uniform disclosure policies by showing that the respect for patients requires more than transparency alone. It requires attention to the meaning of the information and the support patients need when receiving it. One additional point is to emphasize whose preferences these data represent. These responses come from patients who are active on MyChart. So like we talked about, these are individuals who have access to the internet, debatably more healthcare literacy, and the resources required to engage with a patient portal and to complete a survey. Patients who have been historically marginalized, who face language barriers, or who are less digitally connected are underrepresented here. So while we do not yet have data from those groups, it's, I think, reasonable to anticipate that these patients with fewer structural supports and lower health literacy may experience even greater difficulty and greater distress when receiving abnormal biopsy results without clinician involvement. So from an equity perspective, beyond just like the ethics of it, this raises concerns about uniform disclosure policies, and they may be disproportionately burdening those least equipped to interpret and cope with serious health information, further widening healthcare disparities. So, some conclusions and some take-home points I wanted to talk about before we get into the Q&A. So, first, patients clearly differentiate between normal and abnormal results. So they are generally more comfortable receiving normal findings independently, as we saw, but express substantial discomfort when receiving abnormal or potentially life-altering results without clinician guidance. Second, this underscores a foundational insight. Not all medical information is the same, which seems obvious, but it's not how our government is treating it. Treating all results as ethically equivalent overlooks the moral weight and uncertainty and emotional impact associated with serious diagnoses and just the human experience in general. Third, current transparency mandates strongly emphasize respect for autonomy through immediate access. However, our data suggests that this emphasis may come at the expense of other pillars like beneficence, non-maleficence, and justice, particularly when abnormal results are released without interpretive support. In practice, we may be prioritizing autonomy in a way that unintentionally is harming patients. Finally, there are important equity implications, as we've kind of touched on. These findings reflect the perspectives of patients who already are engaged with patient portals. Patients who face language barriers, limited digital access, and lower health literacy are underrepresented here and may be even more vulnerable to distress when serious results are released without guidance. Taken together, these data challenge the one-size-fits-all disclosure policies that we're currently thrown into with the Cures Act and support a more ethically proportional approach. We want to support one that respects autonomy without throwing beneficence, non-maleficence, and justice kind of out the window. So that's what I have for content, and I've included my email if anyone is interested, and I'm really excited to hear questions and kind of thoughts and also stories. Every time I'm kind of on the fellowship path, I'm applying to vascular surgery next year, and I talk about this project I worked on during my fellowship, and so many physicians and patients have stories about this. So I'm excited to hear your thoughts.
Thank you so much, Dr. Bosco. That was really, really interesting. I can't wait to hear the final results of your analysis. So I hope you'll share those with us. There's so much to talk about, and I want to make sure that I invite attendees to put their comments in the chat box while you're thinking about those, and then while we're waiting for that, I might just start by thinking about um, some of the things that you brought up about around differences in health literacy
Yeah.
and digital literacy, and sort of who are the people that maybe are using portals at the moment at present, um, and issues around equity and justice that the portals themselves already create because of access to digital access and the digital divide, as it were. Um, we've been puzzling around about this in our group for a long time. This idea about the clarity or the understandability of essentially results notes, all kinds, right? Labs, pathology reports, et cetera. So I wonder if you could tell us a little bit about what you've discovered, at least in the literature or your own thinking, about approaches to making the information, the written information, just easier to understand from the outset.
Yeah. I think I'll go back to this slide because I really like it. Okay, so like in the right upper hand corner, like the immunohistochemical stain is, so this gets released to patients' phones. And so, I mean, I just think like I've had family members, and I'm a resident and I'm studying this stuff all the time. And I've had family members who, are sick and have to go to a specialist, and I'll go with them and I'll kind of listen to what the specialist is saying. And even though I'm actively in the healthcare clinical space 80 hours a week every day, I have no idea sometimes the words they're using because it's so subspecialized and so, kind of specific to that disease process. So, I mean, I worry that it's just too much information to be sending directly, and I think that most people would agree with that. What I've seen in the literature on how to kind of remedy this is not necessarily thinking about it from an ethical perspective of autonomy versus beneficence, but maybe making the portals themselves more explanatory. So having definitions, like you could hover over immunohistochemical stain and it could either show you a picture or pull up a video of what that is, or that's one example I've seen in the literature. Or I can't, that's probably the best one I've seen, but I still worry about that because for equity concerns, number one, because there's just people that don't have access to that and aren't going to benefit from that. And then two, that's still taking that human interpretive element out of it. Like, what does that mean in the course of that patient's life? That's still, that if we explain and define all these terms, is still not going to cut it. And they're still not really going to understand the gravity or how to really conceptualize what this diagnosis means and what it looks like going forward. And that's really, in my opinion, the role of the physician, to sit there as another human being and be like, hey, you have this diagnosis now, you care about X, Y, and Z. How are we going to get you through this together and make sure that you can achieve those goals, or how are we going to kind of think about that? So I don't know if that answers your question, but those are some of the things I've seen out there.
It's so interesting. That just raised you just raised a bunch of other questions for me.
Yeah.
I've certainly heard people I may be hoping or projecting that AI is going to come along and provide us with some approaches to helping with some of these issues that you've raised for us here. And I'm hopeful in that I'm in the hopeful camp as well, although I bring a fair amount of skepticism to how well it'll work, but I'll remain hopeful around that. But I do think your point is, I guess we're never going to be able to take out that human element. We're never going to have a machine that will be able to interpret the meaning at a individual person's level, right?
Right. Right. And that's so much of what our residency training is. Like we learn obviously all of the science behind it, but I think the things I learn the most from my attendings right now are approaching the patient where they're at and learning what this means in the context of their life and how to kind of choose the right diagnose or the right treatment path for them. So, and I just don't know. And with AI and ChatGPT and all of this stuff, that's just information, I would say. That interpretive element is still not there. If it could, I mean, theoretically it could be, I guess, but I don't think we're there yet for it to be successful enough to bridge this gap.
Absolutely agree. You brought up something else that I think is an interesting avenue for us to explore, and that's this idea about sort of the relative weights of different types of information, um, which which maybe links back to this AI question eventually. Well, maybe I'll come back around to that. But I think that that's like it poses a really interesting philosophical conundrum about how do you know how an individual person's going to weight something. For example, we talk here in our training for our medical students a lot about how essentially any diagnosis might be really bad news for an individual person, and it might be something simple, right? If we think about bad news being something that changes your perspective on the future, it could be a diagnosis that your kidneys are not working quite as well as they were last year, which relatively speaking we might think is less sort of carries less gravity than a cancer diagnosis,
Right.
but maybe it does. But how are we to know?
Right.
And I wonder how, if we were going to try to um, address some of the issues that you're raising for us here by somehow trying to imagine which types of information patients would want to receive independently and which ones they'd want to have their hands held a little bit more on. How would we ever be able to decide that?
Yeah, no, I've thought about that too. An example of this is we just had this patient in clinic and we needed to do a simple procedure. And it was so distressing to the patient that she would have to potentially have a breathing tube in to get this surgery done. And then getting to know the patient more, she was a opera singer. So she was just absolutely distraught by the thought of having an intubation and if her vocal cords were to be injured, god forbid, and it's her career. So I totally agree with that, and we see it every day in clinical medicine. And I think it kind of brings it back to what we're hoping for, which is just more human involvement in it. So taking it away, because to your point, you're never really able to know what is going to stick with someone more or less. I mean, we have an idea that if you're diagnosed with cancer and that obviously is a huge deal, and everyone would have a reaction to that. But if we're taking the human out of the loop for everything, even kind of more benign findings, some will still miss a subset of people who need kind of human interaction through that. So I think it just pushes it back towards having more human interaction than less, and kind of de-emphasizing the central role that these portals and kind of immediacy of all healthcare data have kind of taken in society. So
Interesting. Yeah. And I want to make sure just to, again, invite attendees to put comments in the chat if you've got them. Fabrice, I imagine you have some things to say here. I have something you just said triggered something for me, which is that I'm in primary care. I'm a family physician, and I have patients who've had a number of cancer survivals, right? Who've been through cancer, treated, and have been cured, who are not as afraid of cancer anymore, right? That word, we always just assume, right, that that's kind of be the worst word you could use with a person. But I know some individual patients who that term doesn't bother them as much anymore, because of their own lived experience. So just making this even more challenging to figure out how we'll I guess address these differences in weighting.
right. Yeah, having a sense or trying to get a sense of what is actually emotionally sensitive or psychologically harmful. That definitely is always a challenge in healthcare.
Yeah. We spend a lot of energy here in our medical school teaching medical students, and to a lesser degree residents, but certainly our medical students, about this kind of clear communication, health literacy fundamentals, the ways people do and don't understand health information. And with you, I'm really just so pleased to have you, who, you know, still amidst your training, um, sharing with us today, because you bring a really important perspective, I think, that sometimes is missed in a lecture series like this, which is that, you know, that you're on the front edge of the 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 learning itself, right, and the transformation, if there is any, that's occurring. I'm just curious if you could reflect a little bit about what you think the state of training is like in around these issues around understandability, and communication.
Yeah. This Fabrice and I have actually thought a lot about this. He was my mentor when I was in med school, and we talked about apprenticeship and just kind of thinking about how medical training happens. And it's so interesting because we do 2 years of preclinical where we learn all the science, and then we do 2 years of clinical where we kind of decide what type of doctor we want to be. And that's based off of our interests and experiences within certain specialties. So I decided surgery. And then I feel like I've become a different person totally since my surgical training started, because you can't know really what residency will throw at you and how it kind of changes what you thought your goals would be. I think I guess a critical way of looking at it is I don't know how well our institutions, and even my institution, who had a great bioethics center and excellent professors like Fabrice and Dr. Dursey and stuff, really teach you kind of how to have some of these difficult discussions and really kind you know put yourself in the patient's shoes. And I don't even know if it's possible until you get thrown in to do it. Like I'm sure you think the same thing, Clip. Like you just kind of have to be the one to go through it with patients and see it to the end. But I do think there is kind of a positive shift in doing less of the preclinical years, so less of kind of really basic science, biochemistry and chemistry and those sorts of things, and getting into the clinics earlier, I think is good. I've actually, my future brother-in-law is in med school now, and he's younger and already in clinics, and I think is getting better training for it to be kind of on the ground with patients. But still, I think there is definitely room for improvement on issues like this, particularly from an ethics lens. It's just not something that has been traditionally kind of focused on, I think. And then another point for a group like this is, I know I focused on principalism in this talk because that's what we're taught in med school, to think about ethics from the 4 pillars. But, there's so many ways and so many different lenses to look at ethical practice through. And I think exposing med students to that earlier on could be helpful as well, as they start to think about how they're going to make difficult decisions as a physician in the future. Sorry, that was a long answer, but lots of thoughts about that.
Yes, yes, I appreciate that. We have a comment and a question in the chat box. I'll just read these off for us.
Cool.
So for Andrea, there's a comment. Just had a patient yesterday learn from genetic NIPT result that now her pregnancy/child has a chromosomal abnormality. Would love to have some safeguards or delayed release options without it being illegal. Would love to have time to research a diagnosis also, since I had to call her immediately, even though I didn't have enough information. I have received a bad diagnosis by my chart myself, and it was tough, even though I'm a physician. Yeah, so
It's almost dystopian, some of the stories, honestly, because it's and it's also, I think some of our criticism too is it's just against kind of medical. It's just not how we're taught to, disclose and think about these life-changing, sensitive moments in people's lives to just kind of send it out like it's nothing. So I'm sorry to hear those stories, and I hear a lot of them and see a lot of them in residency. So
Yeah, likewise. Um, Tina has a question. Are there any considerations made in this federal act for patients with significant mental illness, history of severe clinical depression, PTSD, etc.?
No, this is no, not specifically. And this is kind of where our question about previous, I mean, we could have a whole study kind of just focused on psychological kind of safety and relations to previous mental health diagnoses, because I think there's specific considerations for people with those diagnoses, and you want to have trauma informed care and those sorts of things, but that is in no way built into this currently. It's just a blanket statement that everything has to be released as soon basically as it's finalized. So
Yeah, wow.
And Cliff, we did have some questions earlier on in the talk that I can pull.
Oh,
One from Susan Toll. You have faced a challenge of only 10% response rate, and respondents tend to be more highly educated. Perhaps the non-respondents are even more distressed by confusing language in a pathology report. Have you considered interviewing patients after they received a life-altering pathology report?
thank you so much for your question, Susan. Yes, I think this obviously is a very limited study that I wanted to do something that I could design and accomplish within a year, because that's all I had from my, fellowship kind of ethics training. But I think getting more qualitative data on this is critical, or talking to those people that did have life altering diagnoses sent to their to their inbox, and what was that like, and kind of getting more qualitative data around that would be really pivotal to understanding this more completely. So thank you for your question.
thanks for pointing that out, Dave. I'm sorry I missed those earlier comments to those who put those in. Let me jump to Judith Baggs, who said, I wonder if among those with lower health literacy who are less digitally expert, that there may be also more distrust of the healthcare system and more dis-ease, I think, with waiting for physician involvement before they receive results.
Yeah, I think this is super critical too, and this is something that, being at the University of Chicago in Hyde Park, in that whole kind of hospital and area, has a really large population of patients who distrust the healthcare system completely, just based on redlining in Chicago and all of these horrible things from the past. So I do think that this is a major part of this, and unfortunately is not something we capture here. But and then another thing that I thought of based off of this question is, if we are delaying certain things, it would have to be fair for everyone too. Like, there can't be a preferential delay or preferential immediacy. And I mean, even though there already is, right? Like, certain people don't have access or don't have a cell phone. So, I mean, we're trying to kind of balance all of these factors with this. And I think it's honestly just it could be making distrust worse. So.
Agreed. Yeah. Thanks for that question, Judith. And then Fabrice has a comment and question here too, and I apologize for calling you out earlier on that. I didn't see your question. I didn't see it before, but Fabrice says an exception permits delaying the release of EHI when a licensed healthcare professional has a, quote, a reasonable belief that the practice will substantially reduce a risk of harm to the patient or another person. Any thoughts on an ethical framework for clinicians seeking to apply the quote unquote preventing harm exception to information blocking?
Of course, Fabrice calls this out. I didn't have time to get into the 8 exceptions to the information blocking, so I'll have to send them to you. But so as Fabrice is pointing out, there are 8 exceptions to this rule. This is the one, and I did a deep dive into this. This harm principle is the one that I was excited about. I was like, oh, they have a harm exception. Like, why don't we just use that and kind of have an argument that in these cases, like cancer or HIV, that it's not, but the language, if you actually read the document that the Cures, like the actual document of the Cures Act, it is very specific physical harm, and it's only if you know that someone is actively suicidal or something like that. Like you have specific instances or reason to believe that they physically will be harmed by themselves or another person if you release this information. It has no protections for psychological or emotional harm at all. And I can send that to you. But and I was a little bit disappointed by that. Like it's just physical harm we care about, I guess. But at least they have that as an exception. So
Interesting. Okay. And then we've got about 3 minutes here. Hopefully we can get the last of these in. From Ellie, we have, what impact has the COVID pandemic had on patient expectations with test results? Thinking about more frequent exposure to testing for people, eventually very immediate and widely available testing, and immediate impact of test results on people's lives, i.e. isolation.
yeah, what a great question. I haven't specifically, so all of this was during the pandemic. So the Cures Act, the final rule came into effect in 2021. So this was all within the pandemic. So it would be hard to have like a control group of cures like pre and post pandemic, but I think it's a really important consideration because as we all know, patient like telehealth has taken off now post COVID. Like so many of our post-op visits for gallbladders and like we would see those people in clinic, and now, you know, we're much more comfortable having our patients at a distance after COVID and only seeing things that we like, you know, need to, whatever that means, in person. So I think that this is a really important question to consider, and definitely is a part of this whole discussion. Yeah.
All right, let's try it if we can get to this one last one. We have, in your preliminary data analysis, are there any surprises? It's not counterintuitive that patients want a doctor to be there if and when there is bad news. Was there anything you didn't expect to see? Good question.
Yeah, that is a good question. I guess I was I agree. It makes total sense from a patient perspective that you'd want your physician involved. I think I was surprised by the big discrepancy between abnormal and normal, because that's something I, as a clinician, kind of would like understand, but people really don't want abnormal results without context. And that seems obvious when you say it, but the previous literature that I kind of started with for the background of this study wouldn't suggest that. It kind of suggests that people want everything as fast as possible if it's normal or abnormal. And when we ask people who are actually getting biopsies, who might get these kind of big diagnoses or at these big life points, that's not true. If it's abnormal, it's even more important to have a person there interpreting it with them. So I think I was surprised by that the most.
All right, thank you for that. Well, we're at the top of the hour. Dr. Bosco, really huge thanks for joining us and sharing these really interesting cutting edge research that you're doing, and we'll look forward to your final results. I want to remind people that Dr. Bosco's talk will be posted on the OBHC website for you or for others, colleagues who were not able to attend today. And then a quick plug to remind you that the annual Kinsman Bioethics Conference is coming up on Friday, May 1st. This series, the OBHC series, will be taking a little bit of a break until after that. So our next OBHC presentation will be on Friday, May 15th, and the details for that will follow. So hope to see you all then. Thank you so much for joining us. Have a good rest of the day.
Thank you.